I'm a psychiatrist. I've been working in the Boston area for many years and become interested in this topic over the last 10 years as a result of having encountered a few patients who have been really important teachers for me. At any rate, one of the thoughts I had as Dr. Fortunato was talking this morning was how I'm really interested in this area in contrast to most areas of medicine, because it's so much like psychiatry in that nobody knows anything. And it's just sort of constant exploration and sort of trying to figure stuff out, in ways that are sort of painstaking and sort of partial. It's different from psychiatry in that presumably there is sort of reasonable hope for making progress relatively soon in terms of gaining better genetic understanding of causes and mechanisms and those kinds of clarifications. So that's really exciting. The other comment is just this simple thing that, there's this old story about the 10 individuals who were sort of given different parts of the elephant to palpate and describe, and that's exactly what seems to be going on with whatever this thing is that everyone here is interested in, which has features of CPRS, EDS, mitochondrial disease, you name it. Anyway, so what I'm going to talk about is mostly things that go wrong in patient care when people present with pain problems and functional problems that seem obscure and are hard to diagnose, and they end up getting shuttled off as having conversion disorder or somatization disorder or so forth. So I want to talk about what the concepts of conversion disorder is, and then about how it's actually used and what happens as a result of the way it's used. The fundamental concept in conversion disorder stems from psychoanalysis and is essentially that some kind of important psychological conflict is in some way not adequately addressed by the individual, and as a result, the individual converts the psychic energy of this conflict into a physical symptom. And the physical symptom, because it doesn't have anything to do with a physical cause, will have characteristics that are not like the characteristics of ordinary recognizable diseases. So that's the concept. One of the things that's interesting about this is that it has to be unconscious. And I'll get to some of the things about that are important, but one of the things that's important about this is that the explicit diagnostic criteria for conversion disorder require that the creation of the symptom not be purposeful. It's not factitious disorder, it's not malingering. And as people sort of try to make sense out of all this stuff, it's important to keep in mind that there is a real difference conceptually between a symptom that emerges on the basis of some kind of unconscious mental process on the one hand, and a symptom that emerges as a result of some kind of deliberate, purposeful process, either for financial gain or for some other kind of weird social purpose, like getting attention or having special relationships with doctors, like Munchausen syndrome. So I'm just going to go through quickly what the official diagnostic criteria are for conversion disorder before going on to how it actually gets used and what the problems are with that. Basically, this is, you have a problem that, first of all, this is no longer the actual, this is from DSM-4, which is now obsolete as of the last few months, but it's still in common use. You have a symptom that that sort of looks like it might be a medical problem, but you have these psychological problems that are sort of conflicts, as we talked about. It's not intentional. You can't actually ascribe the condition to a real recognized medical problem. It's the sort of key element of this particular diagnosis and the thing that obviously causes the greatest difficulty. It causes distress. It's an important problem functionally. Now, I have no idea what this means or why it's included in the particular criteria of DSM-4, except for the last part, which is obviously central. It's not better accounted for by another mental disorder. I'm sorry, I still don't know what that means. For DSM-5, the criteria are a little bit simpler, but it's still essentially the same thing. One or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptom and recognized, keyword, right? Recognized neurological or medical conditions. The symptom or deficit is not better explained by another medical or mental disorder. The symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants medical evaluation. That's it. It's a much simpler definition, but it's still the same thing. You've got some important symptom or functional deficit that is unexplained medically and therefore understood to be the result of some kind of psychological process that is unconscious. I just want to go back. It's interesting to notice that between DSM-4 and DSM-5, the explicit requirement that the condition be marked by an explicit emotional conflict has disappeared. It's no longer necessary that there be an explicit emotional conflict that underlies the emergence of the conversion symptom, but it's implicit because, after all, where else does it come from? If it's all in your head, there's got to be something that is going on in your head to create this symptom unconsciously. It's also interesting that in DSM-5, I hadn't actually even noticed this before because I was just thinking about this earlier. What this means, the symptom or deficit is not better explained by another medical or mental disorder. That includes, it's not better explained by malingering or factitious disorder. In other words, it still needs to be unconscious. It's not deliberate. It's something that happens to the patient without the patient having any awareness or sort of conscious sort of intent. Now, these things actually matter. Obviously, just from the point of view of validity of the diagnosis, if you have as a diagnostic criterion that there needs to be an underlying conflict, that's contributing to it, there's something so nonspecific about that you can't possibly ever consider this to be a valid diagnosis, because people always have underlying conflicts, and you can either, there are no exclusion criteria for underlying conflict. Maybe that's one reason that the underlying conflict criterion was taken out between DSM-4 and DSM-5. I really don't know. In terms of the way this particular diagnosis is used routinely, it's important to be aware that it's almost never made on the basis of psychiatric assessment or any other kind of mental health assessment. It's almost always made on the basis of nothing more than failure to arrive at a clear medical diagnosis for the symptom or functional deficit or whatever it is. In other words, it doesn't really, and it's made by non-psychiatrists, by physicians who are puzzled and frustrated, and that's the only basis for it. So it's when the diagnosis is made, it's almost always in a manner that's quite careless, and represents really nothing more than frustration and an effort to explain something that is essentially unexplainable by the person making the diagnosis, and essentially laying the responsibility on the patient's unconscious. In other words, the responsibility is not, it's not that the patient is being blamed for deliberately making it up or sort of trying to get financial rewards or attention or anything like that. The distinction between conversion disorder and malingering or factitious disorder is with regard to this unconscious requirement, which again is not explicitly included in DSM-5, except with regard to it needing not to be the result of any other mental disorder like factitious disorder or malingering. The unconscious requirement is important because essentially there are incredibly profound problems with how this diagnosis gets used. Obviously, in the first place, it leaves whatever the actual medical problem is unrecognized and untreated. The essential accusation of dishonesty that this diagnosis represents is compellingly distressing for patients. It undermines the patient's own genuine subjective reality of what's going on with them. It undermines the trust between doctor and patient. It is, especially for children, I've learned over the last couple of days that it's explicitly powerfully traumatic to be accused, essentially, by a doctor who you trust and revere of being a liar, dishonest. This is how patients experience being diagnosed with conversion disorder, and it occurs to me that as I sort of have thought about the difference between malingering or factitious disorder on the one hand and conversion disorder on the other hand, this is actually a problem with either misdiagnosis, in other words, the people who are making the diagnosis of conversion disorder really mean factitious disorder or malingering, or it's a result of very careless communication between the person making the diagnosis and the patient, in that somehow they've conveyed the message to the patient that this is a result of dishonesty rather than some unconscious process for which the patient is not responsible. Obviously, when you get into thinking about this in detail, again, the whole concept of developing this symptom or functional deficit as a result of unconscious mental processes is just incredibly problematic. There's no way to validate it. There's no way to make any sense of it. And in fact, I don't have anything else to say about that. The other obviously important difficulty is with the way this diagnosis gets used is that it doesn't do any good. Not only does it do harm, but it doesn't ever lead to effective treatment. At least in my experience. I've never seen it, I've never heard of it from anyone that upon being diagnosed with conversion disorder, the patient leaves the room with good ideas about how to proceed to get their symptoms relieved through the process of whatever it might be in the way of psychiatric care. Now, I do want to take some time to talk about actual psychiatric conditions as they present in people with chronic pain problems, kids especially. It's reasonable to think of these conditions as being either primary, that is to say, pre-existing or unrelated to the pain disorder, or secondary, which is specifically emerging secondary to having the pain problems, or possibly as co-caused, which is the concept that I actually like the best because it suggests that there may be some important medical physical process going on that creates both the pain and the other kinds of functional deficits and also problems with focus, attention, fatigue, depression, and so forth. In terms of primary problems, there are a lot of important, highly prevalent psychiatric disorders that affect children and teenagers, especially in the areas of learning disabilities, ADHD, anxiety, depression. These are all very prominent conditions that are the sort of routine basis for psychiatric care with kids and teenagers. In terms of secondary conditions, it's very common for people who have chronic pain to develop problems with depression because it hurts a lot, you lose a lot, it's painful, it's demoralizing, it sucks. Anxiety, because after all, there's a whole lot to worry about when you can't do anything and when you're hurt all the time. And also explicitly PTSD. This is something that I just really wasn't aware of until I spent the last 2 days interviewing children and their parents for the documentary that TCAPP is working on constructing, and learned how seriously kids are traumatized by this accusation of conversion disorder and what a compelling impact it has over time, both in terms of continuing anxiety symptoms and especially in terms of suspicion and aversion to any further kind of either medical or psychiatric intervention. It just makes it really impossible to carry on from there. And obviously PTSD as a secondary mental disorder includes the PTSD that can stem from multiple medical procedures and workups and surgeries and so forth, many of which end up being painful and not particularly satisfying. The co-caused issue, this is something I also learned in the last couple of days, is this whole business about brain fog as a manifestation of dysautonomia and anxiety problems, and also fatigue, which should be up there, as either secondary manifestations of dysautonomia or perhaps as some kind of primary sort of parallel process stemming from whatever the sort of underlying metabolic or functional physical deficit may be that we don't really understand. Now, the point I want to make about bringing up all this stuff about real psychiatric conditions is that for kids who have these kinds of problems and who are at risk of being labeled as having conversion disorder or being crocs or making it up or whatever, one of the risks of sort of being in that category is that the actual real psychiatric conditions that they have end up not being treated. And so it's really important to understand that these conditions do happen. They can be present before or after or during the emergence of the pain problem. And there are treatments that can help. One of the standards is supposed to be that in making treatment recommendations, one would base the recommendations on empirical evidence. That is to say, research about particular treatment sort of being shown to be effective for a particular condition and so forth. Currently in psychiatry, the most research in psychiatric treatment has to do with psychiatric drugs and has shown actually very significant efficacy for certain kinds of psychiatric drugs, especially for problems with anxiety and depression and ADHD in kids and teenagers. There are also research studies that have very good results for quite specialized programs of psychosocial treatment for kids and teenagers, also for problems with anxiety and depression, less so for problems with ADHD. The problem, though, in trying to make evidence-based recommendations for treatment for kids with chronic pain problems is that all the research will have been based on enrolling kids into studies with exclusion criteria. And the exclusion criteria will always be, well, you can't have some other kind of really difficult, obscure, painful kind of medical problem that sort of makes you not like an ordinary person. We want to demonstrate that this treatment works with ordinary people, and we don't want to sort of mess up the study by including people who aren't ordinary. So the point of all that is that in reality, I don't think there's any evidence base for claiming either efficacy or non-efficacy of any kind of psychiatric treatment for kids who have chronic pain problems. So what do you do about that? It doesn't matter. Who cares? The truth is that you can't ever really predict the outcome of treatment anyway. Obviously, it always makes sense to try to undertake treatment based on the best evidence basis that you have. But if you don't have any evidence basis, which you don't, that doesn't mean that it doesn't make sense to try something. Obviously, there are going to be risks to any kind of psychiatric treatment. Both medication and psychotherapy can bring significant risks, but there are also a whole lot of very significant potential benefits. And I guess one of the key messages that I think it's important to be bringing out of all this is that if we can prevent kids from being turned off completely from psychiatry by sort of being diagnosed with conversion disorder and traumatized by that, enabling them to then sort of follow up with treatment that's actually helpful for them, even if there isn't any particular evidence base for it, would be a really worthwhile thing to do. Now, I just want to I'm going to go on and talk about somatization disorder a little bit. It's another category of diagnosis. I have no idea why this exists in the DSM in addition to conversion disorder, because they seem to me to be essentially the same thing. If anybody can sort of recognize from reading these criteria what the difference is, I'd appreciate hearing about it. But before I do that, I want to go back to this issue of unconsciousness. In terms of conversion disorder, the requirement that conversion disorder be the result of an unconscious process not only makes the whole concept sort of impossible to validate, but it also contributes to the terrible interaction that happens between doctors and patients when the conversion disorder diagnosis is made. Because what the doctor says in diagnosing conversion disorder is, you don't really have a problem. You don't have a medical problem. It's actually all in your head. And this is something that is coming from an unconscious process. In other words, you don't really understand what's going on. You don't know what it is that you're doing. I know what you're doing because I am a doctor, and I sort of recognize this process going on, and I understand that you don't know this because you're in the throes of some kind of strange, unconscious psychological process that is outside of your control. This is something that patients love to hear. It bolsters their confidence in the doctor because the doctor can always say, you don't know. You don't actually know what's going on in the back of your head because it's all unconscious. And this is one of the aspects of the process that sort of makes it so terrible in terms of how it works. I've been thinking a lot actually about whether conversion disorder as a condition actually does exist. My guess is that it probably does, but it's probably not very common. If it does exist, the question then would be, how would it best be diagnosed? And upon being diagnosed, how would the news best be conveyed to the patient? Certainly, the answer to that is not, in a casual visit by a doctor who comes in and says, "Great news, you're not really sick. You just have conversion disorder. See you later. What you need is really intensive psychiatric help." I can't provide that, unfortunately, but I'm sure that if you just talk with the office manager, they'll give you a referral. That's obviously incredibly destructive. If conversion disorder exists and is actually validly diagnosed, or as validly as possible, then theoretically the right way to convey this information to a child and a family would be by very carefully speaking with them about what's been learned about the condition, what is actually known and not known about the physical condition, reviewing the various kinds of uncertainties that there are, and acknowledging that there are incredible uncertainties about the nature of the condition, but then also talking about how it may happen sometimes that people who are under stress or whatever can end up having things not work quite right in their bodies, and it can sometimes then be really helpful to do some more exploration about one's psychological functioning, and to do this in a way that is non-accusatory and sort of based ideally on some kind of good relationship where the doctor and the patient actually can trust each other, and where this is not an accusation but rather an effort at sort of further exploration. Now, I haven't ever done this. I haven't ever heard of it done or seen it done. I don't know if it's even possible. As I listen to myself say these things, I hear patients responding, "I know what you're trying to do. You're calling me fucking crazy." Oh, I'm sorry. No, I didn't really mean that. But, sorry. All right. So anyway, I don't know if that would work or not. Anyway, there is this other category in DSM called somatization disorder, which is essentially the same thing as conversion disorder. These are the criteria from last year. They're pretty complicated. All right, so one of the criteria is that you have to have each of the following criteria for over a certain period of time, 4 pain symptoms, 2 gastrointestinal symptoms, 1 sexual symptom, and 1 pseudo-neurological symptom, which not limited to pain. You have to have either that the symptom cannot be fully explained by a known medical problem or direct effects of a substance, or if there is an actual related medical condition, the physical complaints are in excess of what would be expected. Again, this is the it's all in your head criterion. You're making it up. It's not real. And then they're not intentionally produced or feigned. They're unconscious. It's not your responsibility. You have no defense against the accusation. Now, the American Psychiatric Association, in its wisdom, has disposed of that diagnosis as of the development of DSM-5. Somatization disorder no longer exists. In its place now is what's called somatic symptom disorder. Here are the criteria for somatic symptom disorder. 1 or more somatic symptoms that maybe are distressing or result in significant disruption of daily life. Excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following. That is, disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms. Either one or the other of those is enough to get you into this category. And third, excessive time and energy devoted to these symptoms or health concerns. Well, that's, I guess, the third one, excessive time and energy. And then the other major criterion is that the condition needs to be persistent. It has to have lasted for a while. I truly don't think that most doctors understand how traumatic it actually is, how bad it is for kids to be labeled this way. I think that most doctors, once they make the diagnosis of conversion disorder, when you think about how this actually works, it's probably pretty uncommon that the doctor who makes the diagnosis of conversion disorder then carries on a further long interaction with the patient that's helpful and understands what the patient's experience has been. I think, in fact, what happens is that the doctor is then able to feel relief that they have solved the problem. It's probably just some kind of emotional problem. I don't really understand it, whatever. And someone else will take care of it. The problems that process causes for patients are profound, but I genuinely believe that the doctors who sort of take part in this process don't understand what they're doing. They don't have the opportunity to understand what they're doing because they don't follow up with the patients. They don't know whether the conversion disorder diagnosis has in fact led to helpfulness or not. And the feeling that goes along with making this diagnosis is usually one of pretty significant personal frustration and externalization, the sort of effort to sort of lay the blame for the problem on the patient and not really think about it. And that's pretty terrible, but as I said, I don't think people really understand how bad it is, what the sort of powerful traumatic impact it has.
See patients come in after seeing a plethora of physicians. These patients have an enormous chip on their shoulders. They come in angry. They come in depressed. They come in tears. They come with their parents. They come in saying, oh great, someone else is going to call me crazy. And when you hear about the workup they've underwent, a workup that oftentimes was in the wrong direction, a workup that oftentimes was didn't even consider diagnoses. They're, guess what, real diagnoses. How many times have we seen an MRI where a Chiari was missed, just frankly missed? The tonsils are 8 millimeters below the foramen magnum, I don't notice it. How many times have we, Lyme disease, Ehlers-Danlos is not an easy diagnosis, and, oh, they're just stretchy. They're just flexible. We see these patients. Listening to you, frankly, I was brought to tears because all of us have seen the patients come in 6 months, a year, 2 years after being called liars, malingerers, fakers. And I have a feeling that once we try to do what we can do, these patients are going to need a lot longer time with people like you to get back whole.
I think that's, I mean, I just think that's exactly right, and the sort of fundamental important message to be conveying is not only how harmful it is, but also how completely unnecessary it is, and how what the right response when you don't know what's going on to do is to say, I don't know what's going on, and I understand that this is a really terrible problem for you, and I will do whatever I can to help you find someone who can help you figure this out and take care of it. For a diagnosis that is so murky and of questionable validity anyway as conversion disorder, you know, what kind of epidemiological research would you ever rely on to arrive at a prevalence figure for a conversion disorder? So anyway.
So Dr. Barnum, thank you very much.